Good day, everyone, and welcome to ACMQ's educational webinar, today titled Six Sigma in Healthcare, Anesthesiology. Our presenting expert is Dr. Julia Caldwell. She is an assistant professor of anesthesia and perioperative, medicine at Penn State Health Hershey Medical Center. Before we start, I just want to go over a few housekeeping tips through in regards to your needs, etc. Just as an FYI, your audio can be listened through your computer speakers, your mobile devices, or the phone number that was provided in the email, your confirmation email. Before we start, let me go to the next slide. Before we start, just a few housekeeping tips. Today's webinar is being recorded, and you will receive an email of the recording within the next business days. All attendees will be muted during this presentation. If you have any questions for our speaker, feel free to go to the dashboard, which has like Q&A, as well as chat and other functions from your webinar dashboard. Again, your audio is through your computer speakers or your mobile devices, or you can use the phone number that was provided in the confirmation email. We ask you, please, your feedback is very important to us, to just please complete the online evaluation, which you'll be sent after the program. However, what I will also do is put the link to the online evaluation in the chat box. So feel free to complete it right away. It's a very short survey, about 1 minute, and we just want to be able to create programming that you need to meet your educational needs. If you have any technical questions throughout this webinar or at any point during this webinar, please feel free to send me an email at atom@acmq.org. My name is Angelica Tom, and my email is atom@acmq.org. Or you can use the chat box function that is in your webinar features as well. Okay, now the important stuff. I'd like to introduce you to our presenting expert, Julia Caldwell, MD, MHA, CMQ. She is at the Penn State Health Hershey Medical Center and is assistant professor of anesthesiology, and perioperative medicine. She is board certified in anesthesiology, pain medicine, and medical quality. She is also a fellow of the American College of Medical Quality. Dr. Caldwell is deeply passionate about resident education, pain medicine, and medical quality. She is an active leader on our educational and abstract committees within the ACMQ. She also enjoys research as well as providing safe and quality care to her patients and the community. So now it is my pleasure to turn it over to Dr. Caldwell. If you wouldn't mind just giving us a moment to ensure that our system is working. And Dr. Caldwell, please take it away. Go ahead and share your screen and your slides.
Excellent. Well, thank you everybody for giving me a moment of your time, and I hope that this will be helpful. I'm just pulling up my slides right now. All right, does everyone? Is everybody hearing what I'm saying?
We can hear you. We can hear you.
All right.
And I forgot to mention that you're generously taking questions and answers throughout the session. So if anybody does have a question, feel free to put it into the Q&A box, and we will get it answered as they come along.
Excellent. All right. Well, again, thank you everybody for coming by. I know that this is probably a time much better spent, eating cheeseburgers or hanging out with your friends or families. So I appreciate you coming by to see that. I'm going to be talking about Six Sigma in healthcare, specifically how it applies with anesthesiology. Unfortunately, I do not have any disclosures. I'm actively working on obtaining some, but so far no good. The objectives that I have in this lecture that I'm having are to discuss the goals, important terms of an abridged history of Six Sigma to gain somewhat of an understanding and beginning fluency of this important aspect of quality. Secondly, we'll outline the history of patient safety measures in anesthesia and the progress made in the field, and demonstrate how the idea of Six Sigma, as well as several other aspects of quality, have been important in playing a role in ensuring patient safety and quality of care in the field of anesthesia. So what is Six Sigma? To quote one of the very important aspects and leaders in Six Sigma is that it's a quality program that, when all said and done, improves your customer's experience, lowers your costs, and builds better leaders. This is by Jack Walsh, who was a very important aspect in this equality metric. So what it is that it means that you're measuring the quality that strives for near perfection. It's a disciplined, data-driven approach and methodology for eliminating defects, driving towards 6 standard deviations between the mean and the nearest specific limitation limit in any process, from manufacturing to transactional and from product to service. It is a representation that quantitatively describes how the process is performing. To achieve an actual Six Sigma, a process must not produce more than 3.4 defects per million opportunities. It's defined as anything that's outside of the specific specifications. It's therefore the total quantity of chances for a defect is what the opportunity of Six Sigma is called. In order to sort of understand this in English, what we're trying to do is we're trying to go as near perfect, if not perfect, that we can. We are able to measure this and quantitatively say, this is what we want to have done. This is different than some other quality metrics in that you're able to measure this and that you're really and truly shooting for 0. So what are the actual other objectives of this? It's the implementation of a measurement-based strategy that focuses on the process improvement and variation reduction through the application of the projects. These are accomplished through the 2 major different types of methodologies in Six Sigma. You have DMAC and DMADV. DMAC is define, measure, analyze, improve, and control. And it's an improvement system for existing processes that are falling below specification and are therefore looking for an incremental improvement. An example of this would be that you currently have a 4% central line blood infection rate. And so therefore you want to see how you can do to decrease your collapsing rate from, say, 4% to 2%, and how you're going to go about doing that. And DMADV is define, measure, analyze, design, and verify, is an improvement system designed to create a new process or a product at the Six Sigma quality levels. It can also be employed if a current process requires more than just incremental improvement. So this is where you're sort of trying to reinvent the wheel. With a DMAC, you don't really have that as much, but with the DMADV, you usually do that. And so oftentimes this is a new clinic, this is a new type of material that you're using, a new type of process that you're using. And so you actually have to create the protocols, you have to create all of the things that we utilize to work through this. Both of these Six Sigma processes are executed by green belts and black belts and are overseen generally by a master black belt. With regard to Six Sigma, what they do is they indicate the level of experience and education that a person has by the level of the belt that they have. Master black belt is the highest that we have. According to the Six Sigma Academy, black belts save companies approximately $230,000 per project, and they can complete 4 to 6 projects a year. And given that your average black belt salary is about $80,000 in the United States, that's a fantastic ROI. So if you think about that, you're at least saving $900,000, if not $1 million plus per year per black belt that you have involved in your company and the processes. General Electric, which is one of the most successful companies implementing Six Sigma, estimated the benefits were on order of $10 billion during the first 5 years of implementation. And GE became the first Six Sigma in 1995 after Motorola and Allied Signal blazed the Six Sigma trail. And since then, thousands of companies around the world have discovered the far-reaching benefits of Six Sigma. The doctrine is looking at multiple different ways of how to improve processes and how do we improve things that people can understand and make things better for our patients as well as for our workers. Number one, you have continuous efforts to achieve stable and predictable process results. So the goal is to reduce variation. Number two, manufacturing and business processes have characteristics that can be defined, measured, analyzed, improved, and controlled. This is a very large aspect that I think needs to be emphasized, in that we oftentimes think that, oh, well, these are just things that happen. Everything is kind of in one giant big bowl. We don't really have much control over things. Every single process can be measured, analyzed, and improved. Achieving sustained quality improvement requires commitment from the entire organization, particularly from top-level management. There's a lot of folks out there who have been champions and also have been sponsors. If you don't have a correct sponsorship, you cannot get things done without the commitment from the top-level management. The things that make this a little bit different from other prior initiatives are it's a clear focus on achieving measurable and quantifiable returns for any project. Two, it's an increased emphasis on the strong and passionate management leadership and support. And three, it's a clear commitment to making decisions on the basis of verifiable data and statistical methods rather than just assumptions and guesswork. Looking at the history that you have there, Six Sigma was registered on June the 11th in 1991 with the trademark system. And that if you look at it, even starting after that, for example, Motorola attributed $17 billion in savings to Six Sigma. Other early adopters of Six Sigma included Honeywell and General Electric, where Jack Welch introduced the methods. And by the late 90s, about 2/3 of the Fortune 500 organizations had begun Six Sigma initiatives with the aim of reducing costs and improving quality. There's been a lot of combinations lately. For example, you have something called Lean Six Sigma, which utilizes the lean manufacturing, which tries to address process flow and waste issues, and Six Sigma, which is a focus on variation and design control. And these are complementary disciplines that promote business and operational excellence. A lot of different companies such as GE, Accenture, Verizon, Genpact, and IBM use a Lean Six Sigma system. And that if you look at the ISO has published that the first definition of the process and other standards are being created mostly by universities or companies that have had so-called first-party certification programs for Six Sigma. But one of the big things I do want to emphasize is that it is different than Lean. You have Six Sigma and you can have Lean Six Sigma and you can have Lean. Lean management are two concepts that they share similar methodologies. Both are Japanese influenced, but they're two different programs. Lean is focused primarily on eliminating waste and ensuring efficiency, while Six Sigma focuses on eliminating defects and reducing variability. So they are both very complementary, but they are different. You have two different project methodologies. These were both inspired by Deming's Plan, Do, Check, Act cycle. And then you have your DMAIC or DMAIC, and this is to have, again, like I said, that you're improving on existing business process, and your DMADV, which is using projects that are creating new product or process designs. DMAIC is you want to define the system. So you want to look at the voice of the customer, the requirements, and the project goals specifically. So for example, if we're going back to trying to eliminate our CLABSI infection rates, one of the things we would want to define is when are we measuring these infections? How are we determining what is an infection? So are we looking at a positive blood culture? Are we looking at purulence of the tip? Are we looking at an elevated white count? Are we looking at erythema at the site of insertion? How are we defining that and at what time? So for example, are we looking at it every 24 hours? Are we looking at it on the third day of placement? How are we having everything set? You want to be able to measure key aspects of the current process and collect the relevant data. And you want to calculate the as-is process capability. What this means is that you want to be able to say what is currently happening. I mentioned, just for numbers purposes, saying that you currently have a current CLABSI rate of a couple of percent, and you want to try to get to less than 1%. You want to say, what is my current process? How many times do we have these infections, and what we can do? You then analyze the data to investigate and verify cause and effect relationships, determine what the relationships are, and attempt to ensure that all factors have been considered. You want to seek out root causes of the defect under investigation. So, for example, you might find that when you start investigating that you notice that people are not really keeping sterile technique very well. Or you want to say that people are not always having somebody who isn't sterile when they're there to place that, and so they may be breaking sterility in order to get what they need. You may find that they're not wearing masks when they're placing these. Whatever you can think of that may be helping to increase your infection rate. You then want to improve or optimize the current process based upon your data analysis using your techniques such as design of experiments, poka-yoke, or mistake proofing. What that means is that you want to try to make things as easy and as understandable and not susceptible to making mistakes or having variation. And standard work to create a new future state process. Set up pilot runs to establish the process capability. So for example, what you would do here is say that you think that you need to create a central line cart, and that you want to have all of the materials that are needed to put in a central line safely and appropriately in that cart. And then you want to make that cart up. You want to do multiple runs to see what you could do to improve upon it, what needs to be added, what needs to be changed. You then want to control the future state process to ensure that any deviations from the target are corrected before they result in defects. And implement control systems such as statistical process control, production boards, visual workplaces, and continually monitor the process. This process is repeated until the desired quality levels are obtained. Some have oftentimes added a recognize step, which is to recognize the right problem to work on. What this means is that you want to pick fruit that will have that are maybe easy to fix, may have a large financial component to fix, may have a large patient safety aspect to fix. Any of these, what we can do to help improve that. DMADV, again, this is the one that is known for trying to create a new process. So say, for example, you're just have a new type of endotracheal tube, and you've had, unfortunately, a number of times where the patient's been extubated because the endotracheal tube isn't staying in place because there seems to be some problems with securing it. So this would be a new project that you would be doing to try and determine how you can go about making this appropriate. So again, our design goals would be, well, we've never used this endotracheal tube before, so we're going to look at this, see what are the different aspects that make it more likely to be extubated on the patient. You want to measure and identify your characteristics that are critical to quality. So for example, you're figuring out that the main issue seems to be it being able to be pulled out, or you want to see if you're having a problem with its placement, and so therefore people are sometimes may not be placing it in the correct place. You want to measure your product capabilities, production process capabilities, and then measure risks. You then analyze and design your alternatives, design an improved alternative and best suited per analysis in the previous step. So again, this may be that you're like, well, we'll put on a halter every time we use this type of tube because this is the safest way to hold the endotracheal tube. Any of these are ways that we can try to do this. And verify the design, set up again your pilot runs, and implement the production process and hand it over to the process owners. A big thing of what you want to do with this is that Six Sigma is a big emphasis on leadership, and you want to have a big emphasis on ownership. Whoever owns this process is going to be the one to make sure that it continues and make sure that it's successful. You've got a number of different implementation roles associated with Six Sigma. You want to have the absolute professionalizing of your quality management functions. And a lot of times it gets kind of got relegated to the production floor and to the statisticians who are in a separate building even. So what we have here is to define the hierarchy and the paths, career paths associated with it. You have executive leadership. So these are things in the C-suite who are responsible for setting up the vision for the Six Sigma implementation. They also empower other role holders with freedom and resources, and for breakthrough improvements by transcending your departmental barriers and overcoming inherent resistance to change. You then have your champions, which take responsible for your Six Sigma implementation across the organization in an integrated manner. The executive leadership draws them from your upper management champions, or also act as mentors to the black belts. Master black belts, which are identified by the champions, act as in-house coaches on Six Sigma. They devote 100% of their time to Six Sigma. They assist the champions and the guide black belts and green belts. Aside from statistical tasks, they spend their time on ensuring consistent application of Six Sigma across various functions and departments. Black belts operate under the master black belts to apply Six Sigma methodology to specific projects. They devote 100% of their valued time to Six Sigma. They primarily focus on Six Sigma project execution and special leadership within tasks, whereas champions of black belts, master black belts, focus on identifying projects and functions. So that's a very big different portion of the black belts. And green belts are people who take Six Sigma implementation along with their other job responsibilities and operate under the guidance of the black belts. Certification. General Electric and Motorola developed certification programs as part of their Six Sigma implementation, verifying individual commands of the Six Sigma methods at the relevant skill level, and that many have started offering this as certifications to their employers. American Society for Quality requires black belt applicants to pass a written exam and provide a signed affidavit stating that they have completed 2 projects or 1 project combined with 3 years of practical experience in this body of knowledge. The whole idea of what the Six Sigma process comes from is that if you have 6 standard deviations between the process mean and the nearest specification limit, as shown in the graph, the items will fail to meet the specifications. This is based upon the calculation method employed in the process capability studies. Capability studies measure the number of standard deviations between the process mean and the nearest specification limits and the sigma units, which is represented by the Greek letter sigma. As a process standard deviation goes up, or the mean of the process moves away from the center of tolerance, fewer standard deviations will fit between the mean and the nearest specification limit, and decreasing the sigma number and increasing the likelihood of them being outside of the specified limits. One should also note that the calculation of sigma levels for process data is independent of the data being normally distributed, and one of the criticisms to Six Sigma is that practitioners using this approach spend a lot of time transforming data from non-normal to normal using transformational techniques. It must be said that sigma levels can be determined for process data that has evidence of non-normality. Role of 1.5 sigma, it shows that processes usually don't perform as well in the long term as they do in the short term, and as a result, the number of sigmas that fit between the process mean and the nearest specification limit may drop well over time compared to the initial short-term study. Account for this, an empirical-based 1.5 sigma shift is introduced into the calculations. According to this idea, a process that fits 6 sigma between the process mean and the nearest specification limit in a short-term study will, in the long-term study, fit only about 4.5, so it's 6 minus 1.5 sigma, either because of the process mean will move over time or because the long-term standard deviation will be greater than that observed in the short term, or both. Hence, the widely accepted definition of Six Sigma is a process that produces 3.4 defective parts per million. It's actually looking at something that's normally distributed, and so that when the limits are of Six Sigma from the original mean of 0, and the process mean is then shifted by 1.5 sigma around that mean. The former Six Sigma distribution, when under the effect of the 1.5 sigma shift, is commonly referred to as a 4.5 sigma process. The failure rate of a Six Sigma distribution with the mean shifted 1.5 sigma is not equivalent to the failure rate of a 4.5 process with the mean centered on 0. It allows for the fact that special causes can result in deterioration of the process performance over the end, and it's designed to prevent underestimation of the defect levels likely to be encountered in real life. And most of this, to be totally honest, is rather academic, but the purpose is to generate organizational performance improvement. It's up to the organization to determine, based upon customer expectations, what the appropriate sigma level is. The purpose of the sigma value as a comparative figure is to determine whether a process is improving, deteriorating, stagnant, or non-competitive with others in the same business. And Six Sigma is not the goal of all of the processes. This is a little bit more about the math of how you determine these levels. levels. Going on more to what is my main driving force and what I find to be really interesting is what is my field's major job is to keep patients alive, asleep, and without complication. Oftentimes people may feel that with anesthesiology, we just kind of click the easy button, patient goes to sleep, and then we go back to reading the paper and doing crosswords. I wish that my job was that easy. Unfortunately, we do a tremendous amount of monitoring, we do a tremendous amount of resuscitation, and we do a tremendous amount of goal-directed therapy in order to keep patients homeostatic. One of the big things of looking at this is it's a major field of patient safety and quality success. In the 1950s and 60s, the death rate from anesthesia was unfortunately 1 in 1,500 people getting surgery. Again, I repeat, 1 in 1,500 people died from anesthesia in the 1950s. For example, I work in the level 1 trauma center. We currently have 205 surgeries scheduled for today. That would mean that in less than 3 weeks, we would have someone die from anesthesia if we were still looking at the 1950s rates. By the 1970s, the rates had gone to 1 in 5,000, and by 2001, they're 1 in 300,000. Most current one that I saw was from 2015, was looking at your rates about 1 in 350,000. In comparison, if you have someone who's the mortality rate for people from routine traffic accidents is 18 per 100,000 people. So my question is, how has anesthesia changed in 70 years? One of the best things that we can talk about is how the monitoring has changed. If you look at how monitoring initially was, oftentimes patients were given ether. And literally when they talk about dropping ether, that's what they did, was that they would have a handkerchief over the patient's face. They would then drop little bits of ether on that. Ether is somewhat of a respiratory depressant. And when people are given it, they decrease their breathing. When they decrease their breathing, they're no longer breathing it in so much, so they wake up a little bit. And they would just do that. They oftentimes would feel the patient's pulse, but there's not a lot of other monitoring that initially happened. We've now gotten to being very, very intensive monitoring. In any general anesthetic, you have over 20 different vital signs are continually and constantly monitored. We check people's oxygen rates. We check their heart rate. We have a 5-lead EKG running on them, where we usually on the screen have leads. Oh, sorry about that. Usually have leads 2 and 5 on the screen to check to make sure for both ischemia as well as any type of arrhythmia patterns present. We look at how much they breathe, how frequently they breathe, how much oxygen they breathe, how much anesthetic vapor they breathe, how much carbon dioxide they breathe. These are huge swings in the amount of monitoring that we have. We have the ability to know what their blood pressure is every single time their heart beats with arterial lines. We have the ability to know what the pressure is inside their head, what the pressure is inside their pulmonary artery, what the pressure is inside their central venous pressure. All of these are possible for our monitoring. Another aspect is better drugs. Again, as I had mentioned before, initially a lot of the anesthetic that started in America was based upon ether, and a lot of the anesthetics that were based in Britain was based on chloroform. However, we've now gone from having very poorly controlled anesthetics that oftentimes made everyone else in the room a little bit sick and a little bit loopy, to having, and also a lot of them were very flammable, to they're non-flammable. They're very tightly controlled. They're in at least semi-closed systems. And so that we are able to control that and be very much more careful with the patient. We also have muscle relaxants, which are able to make it easy to intubate a patient, whereas previously we didn't have those. We also have a wide different array of drugs that can help control pain and help control nausea. Another aspect that we can look at is improving surgical and anesthetic skills. Oftentimes the definition of what made someone a good surgeon was how quickly they could go or how little blood they lost. Although those are both still very appropriate in measurement of surgical technique, there's been a lot more in terms of what people are able to do. We've in the last 70 years, we now have organ transplantation. We can reroute people's cardiac vasculature, their pulmonary vasculature. We're able to do brain surgery on people who are awake, put in deep brain stimulators, for example, for Parkinson's. And these are all things that have been due to continued improvement in both surgical and anesthetic skills. Improved record keeping is another aspect that I feel that's been very important. It used to be that they would check patients' pulse rate and the respiratory rate, and that would be about the only thing that they monitored. They sometimes would look at people's color, but that oftentimes is not truly indicative of their oxygenation rates. And now, as I said before, we're able to, very, very carefully and precisely measure many, many variables. There's been a recognition for the importance of safety and quality in my specialty. We strive to do things safely. We strive to say that no one should be hurt because of anesthesia. No one should be hurt because of surgery. There's been marked improvement in training. In the 40s and 50s, oftentimes the person who was giving the anesthetic was actually just the junior surgical resident or an older nurse in the operating room. We now have had the development of anesthesia as an actual medical specialty. People are trained in that. It initially was a 2-year residency program. It is now a 4-year residency program with multiple different types of subspecialty fellowships that people can receive further training in, depending upon their interest and acclimations, such as pediatric, palliative, pain, regional, cardiac, and other aspects, and obstetric, for example. There's been a development of this specialty. Like I said before, we initially oftentimes were just the junior surgical resident, and now we have our society, we have recommendations, we have made everything to make this a safer and a better endeavor for our patients. We also have a lot of human engineering factors that have gone into place. So for example, if you want to connect the oxygen pin tubing to an oxygen bottle or to the oxygen connector on the wall, you actually have to have the right connector, and it will not connect to anything other than oxygen tubing. So here's some pictures looking at that one. This one right here, this is actually your first looking at, they would put the whatever vapor they're having the patient breathe in, and they would drop that in, and then the patient would just kind of suck on that like a peace pipe. You then got further developments of with bellows and oxygen bottles, and then you started to have actual anesthesia machines where you can measure how deep patients were breathing, how much vapor they were breathing in and out, how much oxygen and carbon dioxide they were breathing in and out, and then they continue to develop further and further. And this is one of a relatively newer model. There are even newer models than this one. Some of them are ridiculously brilliant in their ability to do all sorts of things and for self-checking and monitoring and other things of that nature. Another aspect is that this is sort of how we've gone from circuits. We used to have circuits that were made either out of rubber, or some even had animal bladders using for warming ether and chloroform. You then got some development further in the operating room. That's an operating room from the 1960s. You then started having IV fluids become more and more usable and available. This is a picture from Life magazine. A lady who's hanging IV fluids in the late 50s. And then yet if you look at the difference, there's a newborn baby that is next to her, and those are all pumps that are going through and having different types of medication going into that child. And so this is one of those things where we went from very simple to getting more increasingly complex and increasingly useful. Anesthesia has been very committed to patient safety throughout its entire listing. We initially also talk about how even just the invention of anesthesia was one of the most influential events of patient safety. There was a recent article by NIJM that talked about how the creation of the inhaled anesthetic was one of the most important aspects of medicine and of patient safety in general. You have Harvey Cushing went and actually started giving outcomes of his anesthetics that he performed, and then Emery Rovenstein kept the punch card file of the anesthetics he performed as the chairman in the 30s, decades before the invention of your modern computers. And then we started becoming interested in, what are we doing? Are we helping people? Are we not helping people? And the first multi-center study that looked at perioperative mortality was by Beecher and Todd, and this was in '54. And they looked at it, and again, the anesthesia-related in-hospital mortality was 1 in 1560, 1 in 1,500 cases. And again, as I said, if you look at what my current caseload that we have about 200 cases a day, so that's about 1,000 a week. So in less than 2 weeks, somebody would die from anesthesia if we were still in 1954. Beecher and Todd's paper was considered to be a benchmark for the reduction in the mortality rate because it called for multiple safety improvements, and it led to the development of your physiologic monitors, the introduction of newer, safer, and more specific medications, and a culture of self-reflection and continuous evidence-based quality improvement. I think that that's one of the most important aspects of my specialty, is that we're taught from day one that we have complete ownership of the patient. What we do is directly related to their outcomes and their ability to wake up and to be functional afterwards, and how we can continually get better in our care of patients. In 1985, the Anesthesia Patient Safety Foundation was established as the first independent multidisciplinary organization created expressly to avoid preventable adverse clinical outcomes, especially those related to error. So this is a very big deal. For lack of a better term, we decided that we wanted to do information and data gathering for quality before quality was cool. Our mission statement for APSF is that let no patient be harmed by anesthesia. And again, this is looking at, this whole Six Sigma protocol that I had talked about earlier, that we want an absolute zero. We want perfection. The APSF, which has become a model for the National Patient Safety Foundation, brought together anesthesiologists, nurse anesthetists, pre- and post-operative nurses, equipment manufacturers, and human factors experts to collect and analyze data on critical incidents occurring during anesthesia and develop information and drugs to improve patient safety. And since then, they've funded safety research, published multiple educational materials, and influenced with anesthesia equipment manufacturers to design safer machines, more intuitive monitors, and better pharmacologic agents. Another aspect that I think is really remarkable and singular to my field is the Closed Claims Project. This was started in the early 80s to facilitate an understanding of the liability the anesthesia providers had in practice, and to improve patient safety by working with malpractice insurance companies to review cases of adverse events that were involving anesthesiologists. Although CCP cannot determine the rates at which these adverse events occur, the denominators are unknown. It has provided the profession for years with a compendium of the worst outcomes that can occur in anesthesia cases. Cross-pollination of thinking and leadership between the CCP and the APSF have led to 20 years of patient safety improvement projects, including recent changes to anesthesia machine design, prevention of OR fires, and identification of risk factors for post-operative visual loss. One of the other things that I do want to talk about is how the APSF is different and separate from both the American Board of Anesthesiology as well as the American Society of Anesthesiology. So it's not going to be a political organization. It's not going to be duly influenced by one of those aspects that you have there. Another aspect that we have is with the AQI, which is the Anesthesia Quality Institute. The rapid introduction of digital record keeping into clinical anesthesia in the 2000s created new possibilities for improving care that coincided with increasing public and government interest in quantifying the performance of physicians. In 2008, the House of Delegates, which is a part of the American Society of Anesthesiology, approved the creation of a new related organization, the Anesthesia Quality Institute, to be the primary source of information for quality improvement in the Clinical practice of anesthesiology. The initial AQI board included academics and private practitioners and anesthesiologists with interest and experience in quality management and information technology. They were hired to direct the AQI in 2009 and now lead a staff of 15 scientists, technicians, and administrators as the chief quality officer is at the head. In 2013, the AQI became the centerpiece of the ASA's quality division, which includes another half dozen employees in the departments of quality, regulatory affairs, health policy, research, and methodology. AQI launched its first project in January the 1st, 2010, which is the National Anesthesia Clinical Outcomes Registry, which is otherwise known as NACOR. From an initial cohort of 6 participating practices, NACOR now includes more than 22 million records from more than 30,000 clinicians working in 3,000 ORs, ambulatory surgery centers, and other procedural environments. In 2015, NACOR will captured information from 25% of all of the anesthetic cases in the United States. There's no other safety aspect that you have. NSQIP is close to this. However, they do a selected aspect. So many cases per 1,000 are reported, whereas NACOR captures them all. NSQIP is for surgery outcomes. NACOR is built on the universal availability of a core data set of demographic and procedural information contained in electronic billing records, augmented when available by outcome measures and even complete electronic healthcare records, documentation forms for practices using anesthesia information management systems, and anticipates the day when every vital sign, every procedure, and every dose of medication will be automatically recorded. The purpose of NACOR is to facilitate local quality improvement activities by showing anesthesia groups what they do and how well they do it. NACOR's most important reports concern patient demographics, and outcomes display this trends over time, where every group and clinician can use to improve their performance. A big aspect of maintaining our certification is that we all have to do a quality improvement project where we enter our own information into NACOR and then decide some aspect that needs to be improved upon, and then utilizing a Six Sigma project section, we actually go about and have to demonstrate that we've done this and that we've measured it. NACOR also provides groups with national and peer group benchmarks that they can use to facilitate their strengths and weaknesses relative to those other groups and facilities. National benchmarking can then identify both high and low outliers in the performance, leading to the study of the exceptional clinicians and export of their systems to others. What this means is that you look at the people who are performing at 95 percentile nationally, 98 percentile nationally, and trying to see what they're doing right, and then that way you can export that use of system to others. The aggregate data in NACOR is useful not only for understanding local performance and enabling local quality improvement, but also for academic study, forming ASA's advocacy groups, and identifying gaps in knowledge that can be targeted with new educational products. One of the things that they're trying to look at is how to use this in order to help change resident education. Are there aspects that are done either regionally or nationally that residents or shall we say new providers do not know these things, and so therefore we can change residency education and help improve patient quality in that fashion. I've used a lot of the different terms, safety and quality. I wanted to deliberate between those two. The difference between APSF and AQI is the difference between safety and quality. One theory holds that safety is an infinite absolute. Any complex process, such as the delivery of anesthesia, can be made infinitely safer. A dose of an intravenous medication can be checked, rechecked, and rechecked, and each step will add a progressive, smaller implement of safety. Quality improvement, on the other hand, takes into account the incremental cost of each change in this practice and says, how much quality can we afford to give? Quality improvement, therefore, is the application of finite resources, people and time, to an infinite problem. Quality management begins with quality data collection and benchmarking to identify opportunities for improvement, and then addresses these opportunities in sequence from the most to the least significant. The ideal quality management program continuously improves patient safety by gathering data, identifying variance in practice, introducing change, and remeasuring. This cycle of continuous quality improvement leads to progressive, incremental advances in performance as we're ever striving towards zero. Collaboration is another aspect that's very important in the quality and safety in anesthesiology. We benefit from both the APSF and the AQI and from the interaction of the two. The APSF continues to identify important concerns in the safe practice of anesthesia, and AQI participates in its meetings and discussions. Furthermore, the ASA-CCP, which is the Closed Claims Project, is now a registry of the AQI, allowing extension of the digital archiving and online data collection in accordance with data collection modules designed by AQI. Finally, comparison of serious adverse outcomes in the closed claims analysis with patients at risk, as defined by NACOR, has provided specialty with new understanding, as in a recent examination of claims related to massive hemorrhage compared to national statistics on the number of patients at risk in various surgical procedures and categories. So this is one of the very important aspects that we're looking nationally to see what's causing these problems. And then starting in 2000, well, actually, it was supposed to be starting in 2015. It actually is pretty much starting in 2017. APSF and AQI combined to offer a fellowship in anesthesia patient safety, providing a year of funding for an anesthesiologist interested in the scientific study of risks and outcomes. Fellowship awardees learn the history and applications of each organization, attend national level meetings, and use the available resources to complete a year-long safety improvement project at their home institutions. And the intention of this is to develop leaders in the next generation and safety experts. Another aspect that I feel that's very important to mention in the quality metrics for my specialty is a leadership registry. It's a simple listing of anesthesiologists nationwide who are active outside of the OR, whether leading hospital units or committees, working for pharmacology or device industries, or participating in federal regulatory aspects. Anesthesiologists play leadership roles in many aspects of modern healthcare, and the AQI's goal is to recognize those who do, celebrate their activities, and provide a platform for networking and mentorship. The AQI is working with other organizations, including the APSF, to populate this registry. The goal is to make anesthesiology the specialty for medical students interested in becoming the hospital and healthcare leaders of tomorrow, especially when it comes to quality. In summary, anesthesiology has historically promoted a continuous improvement of patient care through the identification of rare complications and serious adverse events, the systematized collection of data from routine care, educational products, and the effort to provide improved anesthesia equipment. Moreover, APSF and the AQI have created a synergistic partnership for continuous quality improvement that combines both the micro and macro collection of self-reflective data and is a model for other specialties. For example, I work significantly with a lot of the gastroenterologists that we have. A lot of the numbers that they quote for perforation, which is not a good complication and can result in a patient having anything from having to have surgery to even dying as a result of that, it being about 1 in 10,000 for that. And yet everyone's supposed to have a colonoscopy associated with that. The big take-home points that I want to have everybody understand that is that Six Sigma represents a mechanism for monitoring and improving a process by diligent quantification of your goals. Anesthesiology strives continually for a zero patient harm threshold. From the 1950s until now, we've improved mortality rates from 1 in 1,500 to 1 in 300,000 with multiple metrics. And we're the first specialty to really focus on safety and initiate specific quality metrics and improvements. Thank you, everybody. And do we have questions?
Yes, thank you, Dr. Caldwell, for a wonderful presentation. Audience, feel free to, again, enter your questions in the Q&A option along your webinar dashboard. But we do have a question that has, a few questions that have come in. Dr. Caldwell, first one is, what do you see in the future for anesthesiology in terms of patient safety and quality?
One of the big things that I see is that we are going to continue to get better. 1 in 300,000 is still not an acceptable number. We want to try to get to 1 in a million, or maybe even truly get to Six Sigma levels in terms of that. Continue to improve monitoring and to continue to improve the safety of the drugs that we give.
Thank you. Okay, let's see. Our next question is, why do you feel that anesthesia pushed into the field of quality and patient safety earlier than other fields? Why do you feel that anesthesia pushed, into the field of quality and patient safety earlier than other fields? Does that make sense? How
Yes,
I
it
wrote
does.
that? Okay.
Okay. At least this is what I think they're trying to ask, and if not, please feel free to send another question. I think that one of the big things was that it was our actual specific job to keep the patient safe and to do what we can to keep them doing well during complex surgical procedures. Surgeons obviously have very, very difficult jobs, and that they are oftentimes concerned with doing those specific tasks that are needed to do whatever, say if they're doing a Whipple procedure or doing an endoscopy or any of that nature. Whereas with anesthesia, we have, for lack of a better term, the luxury to be able to focus purely on how the patient is doing during the surgical procedure or operation.
Thank you, Dr. Caldwell. Our next question is, what are the main points or lessons learned by your field that can be applied to medicine and other fields in general?
I think one of there's a couple of those. First, you want to really truly understand what you're monitoring and why you need to monitor it, and improving your monitoring. For example, if you're looking at diabetics who have hemoglobin A1Cs of a certain level, if you can improve how often those are checked and how often and frequently you need to check those, that can help improve patient satisfaction. That can also help improve the patient's glucose control and therefore improve their decreased nephropathy or neuropathy levels. Another aspect I feel that is very important in my field is that there's a very key representation of ownership, and that we are truly responsible for everything that happens with that patient. And I feel, not to say that other doctors aren't, but it's something that can be really useful and helpful in all fields of medicine.
Excellent. Let's see. Okay, our next question. How do you think the field of quality and patient safety has benefited from the changes made by anesthesia?
I think that we showed that having national organizations devoted purely to patient safety would not only be possible, but plausible and useful. We've also shown that you can have tremendous gains in improvement in patient safety. As I said before, we're looking at from the 1950s, from a death rate of 1 in 1,500 to now we have a mortality rate of 1 in 300,000 to 1 in 350,000. They show that if everybody works together and you adapt certain very simple metrics, that you can help improve how the patients are doing and improve the quality of care that you give.
Excellent. Our next question asks you, why do you think that the push towards quality occurred in anesthesia?
I think that a couple of things. First and foremost, like I mentioned, that article that was written by Beecher and Todd, nobody knew that the death rate was that high. I feel that that was a very big call to action for people to say, oh my gosh, we're killing people when we're doing this. Because I think oftentimes, especially in the 50s and 60s, providers were very singular and they didn't have as much interaction with each other. For example, there was no social media. Television had just pretty much started, and it literally wasn't something that was talked about in medical journals. And so I feel that this was a very, very important aspect, to sort of a call to arms for people to realize, wow, we need to not hurt people.
Wonderful. Well, Dr. Caldwell, that seems to be our last question. Thank you, audience, and thank you, Dr. Caldwell, for being here today. This presentation will be, an archive of it will be emailed to all, as well as a digital copy of Dr. Caldwell's slides. Let's see, there's also a webinar evaluation that we would greatly appreciate you completing. You actually can do this right now if you look at your Zoom webinar chat in your webinar dashboards. And around 12:07, I put in a link. If you click that Survey Gizmo link, it'll take you to an online survey, which will which will allow you to just take this 1-minute survey to tell us what you think today and what kind of content you would like to see in the future. That's pretty much it for our webinar session today. So thank you once again, Dr. Caldwell. Thank you, audience. There is just one other thing that I want to bring up. Let's see, in terms of, here we go. If you're not an ACMQ member, we greatly encourage you considering becoming one. Oopsie daisy. The American College of Medical Quality was built as a place for your education and your ways to network and advance in your careers. Please click on the link that you see at the bottom of this particular slide. Also, feel free to get in touch with us at any time if you're not a member and interested in learning about membership. If you are a member and looking at ways to increase your involvement, feel free to contact us at info@acmq.org. That is it, audience. We thank you for being here today, and good day.